He is Dr. Brian Fallon, who is a professor of clinical psychiatry at Columbia University. He's the director of the Lyme and Tick-Borne Disease Clinical and Research Centers at Columbia University. And I know he's recently published a very informative study with respect to mental health and Lyme disease. And I'm sure he's going to discuss that here. The title of his talk is Depression, Suicidal Behaviors, and Lyme, Results from a Nationwide Study in Denmark.
Thank you, Monica, and thank you, John, for that terrific talk. So my topic is Depression, Suicidal Behaviors, and Lyme Disease, Results from a Nationwide Study in Denmark. I do not have any financial arrangements or affiliations with commercial entities, and I will not be discussing off-label use of meds. So a very important message I want everybody to take home is that most mental disorders, of course, have nothing to do with Lyme disease, but some do, which is the theme of this talk. Why would people have neuropsychiatric symptoms? Well, we know that acute or persistent Borrelia or Borrelia remnants can trigger inflammation, and the inflammation could be systemic or it could be central in the brain. Autoimmune mechanisms you've heard about, such as molecular mimicry, that may lead to neuropsychiatric symptoms, or the systemic infection or the central infection can alter the neural circuitry and cause changes that persist, such as central sensitization, where the brain pain pathways are hypersensitized so that even a mild touch is experienced as painful. And in addition, people might have neuropsychiatric symptoms for other non-biological reasons, such as prior trauma. And that trauma could be prior infections, it could be prior medical illnesses of other sorts, it could be psychological trauma, physical trauma, whatever. Current stressors such as pain, economic stress, interpersonal loss, uncertainty about diagnostic tests and treatment options are a huge problem with our Lyme disease patients because we don't have the answers necessarily to help these patients in terms of diagnosis and treatment. So that increases neuropsychiatric problems. Cognitive deficits are well known in post-treatment Lyme disease. Up to 90% of people who meet criteria for post-treatment Lyme syndrome complain of cognitive difficulties. A smaller percent of those actually have objective measurable problems, about 7 to 30%. And that's when you do neuropsychological testing. And when you do that, you'll find that people often have short-term memory issues, verbal word finding issues, and slower thinking speed or slower processing speed. Another important finding is that these measurable cognitive deficits are present even in the absence of depression. So even though depression can lead to some cognitive problems, especially slower processing speed, among non-depressed patients, you can also see these cognitive deficits in our post-treatment Lyme patients. On average, the cognitive deficits are mild in severity. Some have severe problems, but most have mild cognitive problems. And what we don't know is really what is the optimal treatment for these persistent cognitive deficits. Now, our prior studies using PET imaging showed that the post-treatment Lyme encephalopathy group, or the group that had cognitive impairment, showed decreased regional metabolism, which is what you see here. These areas in red and yellow are all areas of decreased metabolism in patients compared to controls, and a diminished ability to enhance blood flow. So a healthy person might look like this on the blood flow studies at rest, and then after a carbon dioxide inhalation challenge, there's a massive increase in blood flow. But what you see in the Lyme patients is only an 8% increase in blood flow compared to 28% for controls. So there appear to be both metabolic and perfusion deficits in our Lyme patients with persistent symptoms. And as John pointed out before, There's also evidence of diffuse microglial activation in patients with post-treatment Lyme symptoms compared to controls. And as Stephen Schuster has shown in the prior studies in 2012, the spinal fluid of our Lyme patients demonstrates about 692 unique proteins. That's not there in patients with chronic fatigue syndrome or healthy controls. And similarly, chronic fatigue patients have over 700 unique proteins that aren't there in the Lyme patients or the controls. So even though the symptoms overlap quite a bit, there also are biological differences between those disorders. Now, I'm presenting two cases here just to give you a flavor of what might happen when patients with Lyme encephalitis present with severe psychiatric disorder. So here's a 55-year-old woman who presents with a new onset manic psychosis. She was out camping with her family. I think this was Sweden or Norway. And she was doing fine. And all of a sudden she started to develop hyperenergy, a euphoric mood. She couldn't sleep. And she ended up being brought to the emergency room because of her bizarre behavior. And then she was admitted to the psychiatric institution of the hospital for the diagnosis of mania or bipolar disorder. But it was very unusual because she was 55-year-old and had been previously completely healthy. So it didn't make any sense that this woman would suddenly develop mania for no reason. And then, so they were wondering about a medical cause. But then she started developing radicular pain, shooting pains, as well as muscular weakness. So that led them to suspect neuroborreliosis, neurologic Lyme disease. So they did a spinal tap, but it wasn't positive. But the cluster of encephalitic symptoms and radiculopathy made them think that this probably was neurologic Lyme disease, but the spinal fluid hadn't turned positive yet. So they treated her with antibiotics and she got dramatically better. And then they repeated the tap 8 weeks later. And it was positive. So an initial negative spinal fluid result should not lead to the false conclusion that this isn't neurologic Lyme disease. So that's one important point from this. Another point is that psychiatric symptoms may be the first presenting symptoms. Next case is a 42-year-old woman who presents with new onset schizophrenia-like disorder. She started with cognitive problems and irritability. And then this evolved into paranoia and hallucinations. And this was going on for about 8 months. She was hospitalized. Finally, because again, she was older and she had never been sick before, they thought, well, let's do a really complete medical workup because she wasn't getting better with the standard medication. So they did a lumbar puncture and neurologic Lyme was diagnosed. No systemic physical signs or symptoms of Lyme borreliosis were present in this patient, however. So that's a little bit troubling because it does make you wonder how many people with persistent psychiatric illness might have unrecognized Lyme disease infection. She had a full recovery after antibiotic therapy. But these cases would not be surprising to neurologists who are used to working with patients who have encephalitis, because anything that causes encephalitis can cause severe psychiatric disorders. We got interested in this, as many of you know, early in the early 1990s, as a result of Polly Murray, who was the mother in Old Lyme, Connecticut, who brought Lyme arthritis in children to the attention of the authorities, when she asked us to take a look at what the psychiatric manifestations of this disease might be. So we sent, my wife and I, actually, Jennifer Neal, sent a survey out to 1,000 people who had been diagnosed with Lyme disease. It was a community survey. And what we found was quite surprising, that the rate of depression in our Lyme patients was 2.5 times higher than it was compared to the patients with non-Lyme arthritis and compared to lupus patients. So we thought that if patients were experiencing depression because of pain, that they would have similar rates as the arthritis patients, or if they were experiencing depression because of inflammation, they would have similar rates as the lupus patients. But in fact, the Lyme patients, by report, had higher rates than both groups. The other anxiety disorders, panic attacks, and generalized anxiety were not significantly different. And then Afton Hassett did this very nice study in 2008, where she compared patients with chronic Lyme disease who had well-defined prior Lyme disease and patients who were described or self-defined as chronic Lyme disease, but who did not have good solid histories for prior Lyme disease. So she called it medically unexplained symptoms. And then there was a group of Lyme disease patients who recovered and medical controls who didn't have Lyme disease who were included in this study. And interestingly, what they found was that depressive comorbidity was 4 times more common in the definite Lyme disease group versus those with medically unexplained symptoms who thought they had Lyme disease, but didn't have very good evidence for it historically. So there's something about Lyme disease and affective disorders that seem to go together. And a few studies have also looked at suicidal ideation associated with Lyme disease. So Dr. Bransfield in 2018 reported on a retrospective chart review from his psychiatric practice. It was a large sample of 253 cases, and 44% of those patients with a history of tick-borne disease reported suicidal thoughts. His was a very heterogeneous group. Some of them had well-defined prior tick-borne disease, others were possible. And in our research center at Columbia, we did case control studies, first with children compared to healthy children versus children with post-treatment Lyme symptoms. And 40% of those reported suicidal thoughts, 11% had attempts, but none of the controls had thoughts or attempts of suicide. But we worried that referral bias obviously would lead to inflated rates, and that has to be true. And then another researcher in our group, Shreya Doshi, looked at suicidal ideation in 81 post-treatment Lyme patients and 70 HIV patients and 44 controls. And as you might expect, the ideation was greater in the Lyme patients and the HIV patients compared to controls. But there's been other studies that have not found an increased risk of depression. These are all follow-up studies of patients with erythema migrans, facial palsy, Lyme arthritis, neuroborreliosis, and they did not find at 6 months or at long-term follow-up 4 or 5, 10 years that there was an increased rate of depression. So that left me thinking, gosh, what is going on with these studies? Well, a lot of the studies suffer from small sample size. There's unclear diagnostic criteria. There's ascertainment bias. Patients are drawn from psychiatric practices or research clinics. And oftentimes there's lack of an appropriate control group. So I was thinking 2 years ago that this is a problem, and I've been studying this for so long, and I still haven't answered this question to my satisfaction in a scientific way. And so I thought, what's the best way to resolve these issues? And I thought the best way is really to do nationwide studies where you include everybody you could possibly include, everybody in the nation. And where can you do that? You can do that in Denmark. At the same time as I came up with that thought, the people in another group in Denmark actually also came up with that thought. And they published a paper in JAMA Psychiatry in 2020. They were asking the question, is the frequency of mental disorders greater after neuroborreliosis versus those without neuroborreliosis? And in our study, which just got published in September in the American Journal of Psychiatry, we asked, is Lyme borreliosis, not just neurologic Lyme, but all manifestations, associated with a higher rate of mental disorders, affective disorders, suicide attempts, and suicide? So we added suicide attempts and suicide to our study. Denmark is a small country just north of Germany. It has about 8 million people, about the size of New York City. So in the study that Tettens did and published in 2020, it was a nationwide matched cohort study of all spinal fluid Borrelia positive cases over a 20-year period. So they had 2,800 spinal fluid positive patients and 29,000 controls. So it was a 10-to-1 match. And the diagnosis of neuroborreliosis was not clinical. It was based on the spinal fluid, but nevertheless was based on spinal fluid, which obviously is an objective marker. And they had 3 main outcomes. Was there a hospital diagnosed mental disorder? Was there an inpatient psychiatric hospitalization? And did the patients who had neuroborreliosis receive a prescription for psychiatric medication in the subsequent years? What they found was that there was no increased rate of hospital-based psychiatric diagnosis or of psychiatric hospitalizations. However, there was an increased risk of psychiatric medication prescriptions during the year after, in the first year after the spinal fluid Borrelia index positive results. These were anxiolytics, hypnotics, sedatives, and antidepressant medications. So we don't know exactly why they were prescribed, but obviously, given what they were given, it's likely they were for pain or sleep or mood issues. And the reason we don't know exactly why these were prescribed is because the Danish registry, as great as they are, they don't tell you what goes on in the community. They only tell you what goes on in the hospital setting. The prescription meds are recorded from the community, but the diagnoses aren't. So the authors concluded that the short-term affective symptoms of Lyme neuroborreliosis warrant further investigation. There were limitations to the Teton study. They didn't adjust for certain covariates that are important, such as education, marital status, socioeconomic status. And the comparator group did not exclude people with non-neurologic manifestations of Lyme disease, as far as I could tell from their paper, and that could be an issue. In our study, which was done in collaboration with the Copenhagen research group, led by Michael Benrose and Trine Madsen and Annette Erlangsen. This was a nationwide retrospective cohort study of all people living in Denmark over a 22-year period, so 6,900,000 people. The exposure, what was the hospital diagnosis of Lyme borreliosis, either as an inpatient or someone came to the ER, or they saw a specialist as an outpatient. So that was the reason for their hospital contacts, the diagnosis of Lyme borreliosis. And then the outcomes we looked at was any subsequent diagnosis of a mental disorder, an affective disorder, suicidal behavior, or suicide. The age range of the group in the study was 3 years all the way to 104 years old. The number of the 7 million who actually had registered Lyme disease was 12,616, and the comparison group was everybody else. So 6,933,000 comparators. You might ask, well, what problems of Lyme disease did these patients present with when they went to the hospital, ER, or outpatients or inpatient for diagnosis? Well, the truth is it's really not clear, because in Denmark, most doctors give non-specific diagnoses. So as you can see, the most common here was just the diagnosis Lyme disease, 12,000 people. And then some people had numerous other diagnoses, but really there's no way with this database to sort out whether neurologic Lyme or arthritic Lyme causes mental disturbances, just because there's a lot of neuro Lyme and probably a lot of arthritic Lyme and other types of Lyme in the Lyme general group. So we just can't do that. But what we were able to show was that the rate of mental disorders, this is mental disorders overall, any psychiatric diagnosis was about 30% increased compared to the people without a Lyme borreliosis diagnosis, 42% increased compared to those without Lyme borreliosis diagnosis for affective disorders, a twofold increase in suicide attempts after the Lyme borreliosis diagnosis, and a 75% increase in suicide, completed suicide. So those are disturbing findings. So as I mentioned, the rate of suicide after Lyme borreliosis was increased by 75%. Now it's important to note that there were 12,669 suicides in Denmark for all causes during that 22-year interval, and only a small proportion were the Lyme borreliosis cases, So as you can imagine, there are many, 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 many causes and reasons why people might commit suicide, and the association with Lyme borreliosis was a small attributable risk. But we also asked the question, if you have more episodes of Lyme disease, does that increase the incident rate ratio or the risk? And in fact, it did. So as you had more than one episode, the incident rate ratio went up. And that's also true for the number of contacts. As you had 4 or more contacts, the incident ratio went up. That's hospital contacts for the diagnosis of Lyme borreliosis. And then we asked, what about when did these disorders occur? When did these mental disorders occur? And it was usually within the first year, as you can see here, 0 to 6 months, 6 to 12 months. That was the highest incident rate ratio. It also was elevated 3 to 5 years later. But the bulk of it was during the first year after diagnosis. That was for mental disorders in general, but we found the same thing with affective disorders and specifically and in suicide rates. So in terms of temporal proximity, affective disorder was greatest within 6 to 12 months after the first diagnosis. Suicide was greatest during the first 3 years. In terms of number of Lyme borreliosis episodes, the rate increased 2-fold if there was more than one episode of Lyme borreliosis. This was for affective disorders, and for suicide, the rate increased nearly 3-fold if there was more than one episode of hospital-diagnosed neuroborreliosis. And I'm emphasizing hospital-diagnosed just to emphasize for the audience here that this is not your standard Lyme diagnosis of erythema migrans. This is most likely the more severe cases that actually have to go to a specialist or to the hospital, ER, or hospitalization. So this is not the less complex cases of Lyme disease. Similar to the Teton study, hospital-diagnosed neuroborreliosis was not associated with increased rate of mental disorders, affective disorders, or suicide. So we found very similar results to the Teton study, which reinforces, I guess, both studies. As I mentioned, there's problems in trying to figure out exactly what's going on in the subgroups of Lyme disease, mainly because, as the Danish report on Lyme borreliosis said in 2010, a large proportion of patients coded with the nonspecific codes probably had neurologic symptoms. There's also problems with the registry, as I mentioned. We don't know exactly what happens after discharge to the community because the hospital-based data is what the registries are based on. And finally, I do want to make this important point, is this is a study about Denmark. The rates in the US may be different than the rates in Denmark, as we know that Borrelia sensu stricto elicits a more robust inflammatory response than Borrelia grignii or Borrelia afzelii, which are more common in Denmark. So this study doesn't say that Lyme disease causes mental problems. All we can say is that there's an association, but the association certainly is strengthened by the temporal association with the Lyme disease diagnosis, by the strength of the association, and by the coherence of the explanation given prior literature. When we submitted this paper for publication, the reviewers asked, is it possible that another comorbid condition accounted for the elevated rates of mental disorders? That maybe they came in with Lyme disease and some other comorbid condition, and then there was that other comorbid condition that led to the subsequent mental disorders. So we looked at that by removing people who had serious comorbid medical conditions, and we found the exact same findings. So it didn't seem as if it was another comorbid condition causing the elevated or being associated with the elevated rates of mental disorders. Another reviewer asked, well, because 75% of all mental disorders start before the age of 24, do older people have less risk in terms of this Lyme disease association? So we looked at the older group and the younger group, and the elevated risk was similar for the young and the old, suggesting that the reason why people are, if there is a causal factor here, that the reason might be related to something other than the genetic risk for psychiatric disorders that would manifest in children and young adults. So perhaps the inflammation that Lyme disease is known to cause may be accounting for this. So there are multiple strengths to this study. It's a nationwide sample. We adjusted the data for well-known risks for mental disorders and suicide, sex, age, marital status, education, chronic medical comorbidity, and the inclusion of temporal and severity covariates obviously was a strength. Are these results surprising? I would say no. Prior nationwide studies demonstrate that serious infections are associated with an increased rate of mental disorders and suicide. That's very well documented. And many infections have been associated with neuropsychiatric disorders, HIV, Epstein-Barr, SARS-CoV-2, strep, toxo, treponema pallidum. And peripheral inflammation is known to lead to depression, or at least associated strongly with depression. So this is not surprising, the results of our study. And you might ask, well, what are the biological mechanisms by which peripheral inflammation stimulates these problems? Well, peripheral inflammation can stimulate microglial inflammatory cascade, which might lead to depression. So here's the peripheral inflammatory response, here's the microglia, and you end up getting an increase in quinolytic acid. Quinolytic acid actually has been reported in the spinal fluid of patients with Lyme Encephalopathy. That was early in the 90s by Dr. Halpern, who was then at Stony Brook. And quinolytic acid is a potent excitatory neurotransmitter, as is glutamate. And so too much excitation can be neurotoxic. And if you want to read more about the mechanisms for this, Miller and Raison have published some excellent papers. So what is the future research work that's needed for neuropsychiatric Lyme? Well, we need to know, are there genetic or historical risk factors that increase the risk? Why do some people get it and others don't? What are the mechanisms? Is it direct or is it indirect or a combination of the two? Are there biological or neuroimaging biomarkers that help target treatment selection? And really, how do you treat? Psychiatrically, antibiotics, immune modulation? Well, certainly if it's a new onset infection, and certainly if it's an encephalitis, you would absolutely need and want to treat with antibiotics. But what about the patients who've already had abundant antibiotics or different courses of antibiotics? Well, certainly you would want to treat psychiatrically, basically, in addition to whatever else you do, because denying a patient or not providing a patient proper psychiatric care is dangerous, and it can lead to suicide. It can lead to very serious disability and complications. And so it's very important to complement the medical treatment with the psychiatric treatment. They work together, and the brain is affected by inflammation and infection. Because the brain is so important for all of us, we need to treat it well. So please make use of your mental health providers. And just a couple of facts about suicide. Suicides outnumber deaths from war and homicide worldwide. The rates of suicide in the United States, in fact, have been steadily increasing since 2000. So it's a huge problem. We do know from lots of studies that there are prevention methods that are helpful. And the most important are these three: primary care clinicians, those doctors who are treating our patients, primary care clinicians. If they can be better able to diagnose and then treat depression, that will be profoundly helpful, because the depression is the #1 psychiatric disorder associated with suicide, not the only one, but the #1. Better follow-up of suicidal patients during the month after discharge from the ER or the hospital. So if one of your patients actually goes to the ER because of feeling suicidal and they get discharged, be careful, because over the subsequent month, it's well known that the risk of a completed suicide is much higher. And of course, be very, very probing with your patients and ask if they have dangerous items in their house that they might use to kill themselves, which would include removing guns, but also ask about a huge supply of medication that they might have been stocking up for a later suicide attempt. So clinical recommendations are to monitor your patients for mental health sequelae after Lyme disease, especially during the first year. That's what our study supports. Consider incorporating a mental health screening tool in your practice. And these are both free tools. So the PHQ-9 screens for depression and suicidal ideation. It's very, very quick, easy to score. It's just 9 questions. It's a self-report. People can do it in the waiting room. And the Columbia Suicide Severity Rating Scale is also very quick and easy to do. The clinician does this, but it gives you a risk assessment of how severe the risk is. And this scale is widely used around the world and in many hospital settings. And then make sure you refer to mental health clinicians. If you have someone who's struggling with anxiety or despair or suicidal thoughts, the mental health clinicians can help the clinician as well as the patient in many ways, and also provide them with a suicide prevention lifeline phone, which is available on the internet easily. I don't have time, but if anybody's interested, we can talk about our 2 new Columbia initiatives due to the generosity of the Cohen Foundation, the Cohen Center for Health and Recovery from Tick-Borne Diseases at Columbia University Medical Center. We're starting this up right now. It's an affordable clinical center for children and adults. It's research integrated, and it'll also be a training program for family medicine doctors. And we're starting up, or we have started up, a clinical trials network for Lyme and other tick-borne diseases so that we can identify safe and effective treatments. In addition to our team at Columbia, we have our colleagues at Johns Hopkins, led by John Alcott, and at Children's National Hospital, led by Dr. Roberta DiBiase. So I thank you all for taking time today. I thank our collaborators and the Global Lyme Alliance, actually, who are the funders of this very important Danish study. And again, here are the pictures of our colleagues in Copenhagen, Michael Benros, Annette Langson, and Trine Madsen. Thank you so much for helping with this, conducting this important study, and to my team. And thank you all for listening. And here are some references if you want to follow up. And that's the end of my talk.